In the house, Richard Robertson, President and CEO of Mississippi Hospital Association. Good morning, sir. How are you?
Hey, good morning, Paul. Good. How are you doing?
Old friend with a new title. It's good to see you, sir. Very much. You had everything. You had the experience and everything else. I mean, so why not take the heartaches and the headaches?
Exactly. Well, all good.
Thank you for coming in. Can you give us a kind of an update of as far as the hospital association from where we were, several months ago during all of the turmoil and during the election, and where we are now? Have things stabilized a little bit? Do we see a clear path forward, or where are we, Richard?
Yeah, I think so. I think things have stabilized a little bit. Still a lot of work to do for Mississippians, a lot of work to do for our patients. Now, the Hospital Association has been around for almost 100 years now. I'm honored and privileged, blessed to be able to serve our great industry. The patients are going to be top of mind. I was a history major in college and was doing a little research for a speech I gave a few weeks ago, and I came across something from 1934 from Dr. Richard Field. Down at Field Memorial Hospital down in southwest Mississippi. He said the object of the association, talking about the Mississippi Hospital Association, the object of our association is to promote the welfare of the people of Mississippi by the furthering of the efficiency and economy in the institution, care, and management of hospitals, and to improve the care and service rendered to patients by those institutions. Yeah. And that sums up what our mission is. That sums up why we're here and what the association is about.
I wouldn't think you'd waver much from that mission statement over the years.
Absolutely not. It's funny, and again, in doing some of the research and looking back at the minutes of annual meetings, the Hospital Association almost 100 years ago, the big debate then was about establishing minimum standards for patient care and minimum standards for hospitals and trying to put all the hospitals behind a level playing field, so to speak, on the conditions of care, the standards of care that would be rendered. And, quite honestly, the industry was a little fractured back then about what to do and which direction to go, but it was important that they all came together and pushed those minimum standards because that's what was best for patients.
I would guess one of the tasks, or you'd like for it to happen, is to bring back some of the people who left, some of the members who left back into the fold.
Sure, absolutely. Would love to have some of the members back. That would love to have all the members back, but would love to have folks come back in because I think, once again, when the industry is together, when we're on the same page, great things can happen for the state of Mississippi and for our patients.
It's hard not to. I mean, it's a political organization in a way, even though you don't want it to be a political organization. It's like anything else, any business now. You have to mix politics with what you're doing.
Well, our biggest platform is education and advocacy. Those are the two pillars of what MHA does. We provide a lot of education services to our hospitals. We continue to provide those services and make those available to non-members as well. So that has not stopped. From an advocacy standpoint, we advocate for things that are good for hospitals, but are also good for patients, like I talked about 100 years ago, was establishing minimum standards. So advocacy issues, obviously top of mind, things that we do downtown at the Capitol, the ways we work with our state agency partners and with our partners in the federal government as well and our congressional delegation.
The governor's deal that he put together, that equation that he worked out, apparently is proven to be profitable. Explain that a little bit and how it's going.
Yeah, so basically that program, it actually came about in the very early beginnings from my predecessor, Tim Moore. Had a meeting with his colleague in Louisiana, actually at an LSU Mississippi State football game weekend that they were both going to together, both being fans of both schools, and started talking about some things going on in Louisiana that they had just gotten approval for through CMS, and that was taking their supplemental payment and basing it off of not just a Medicare rate, but a commercial rate, which is, as you know, much higher than a Medicare rate. That was really the genesis of what then ended up being just a phenomenally good program for hospitals, which was increasing the supplemental payment rate that Mississippi hospitals pay 100% of the state share cost for in the form of a massive hospital tax. But in return for that, they receive a massive supplemental payment. And that stands on top of the claims payments that Medicaid makes to it for both inpatient and outpatient encounters, primarily through the managed care program. There was also some additional money that was put in for non-managed care patients. But essentially that program pays hospitals at an average commercial rate. And what happened subsequent to the initial offering of that, which was about a $40 million increase in the spring of 2023, I guess, was CMS started approving a different rate methodology that was calculated using what was more of a national average commercial rate. And like many things nationally, if we're looking at our reimbursement levels, we're much lower than a national average. So that was a significant increase there as well. So commend the governor, commend the Division of Medicaid and the leadership for working on that, because it's made a huge difference.
Was it enough to help the smaller rural hospitals?
Yeah, for some it was. The payment methodology is driven a lot by your Medicaid volume.
Yeah.
And so again, volume for our rural hospitals is a challenge in some ways. But yes, it is stabilized. Certainly hospitals like Greenwood, some other hospitals that got a kind of a life jacket, so to speak, for some time. And it has helped tremendously. Long term, there's still some challenges. We still got a very sick population and relatively little money compared to other states to pay for things. But yes, that program has certainly been a big help.
Speaking of politics, and again, Richard Robertson, who's the new president and CEO of Mississippi Hospital Association. Richard, speaking of politics, what do you hear during this campaign, either side, that is either positive or negative as far as hospitals are concerned in our state and elsewhere?
Yeah, you're talking about the federal campaign.
Yeah, I'm talking about the national campaign.
Yeah, I mean, there's not been a ton of talk on health care like there has been in the past.
Mm-hmm.
There's been some still talking about the Affordable Care Act, some things that I think both sides have talked about wanting to change. Lowering prescription drug prices. That's a big deal. It's funny, unfortunately, the timing of it was awful. Back in late January of 2020, President Trump came out with essentially a version of Medicaid expansion called the Healthy Adult Opportunity Waiver. And it was going to cover low-income adults within that 90 to 65 age range that were below 133% of the poverty level. But it wasn't just a simple expansion. There was a lot of accountability in there for providers, a lot of accountability in there for redesigning the Medicaid program to add more value, to give states more options to negotiate better prices and have more leverage on prescription drug buys and formularies that are established there. So, a lot of really good positive things there that were in that waiver opportunity. I mean, just a lot of things that are out there, but I don't think healthcare is quite getting the focus that the economy is, and
I agree with
national security and a lot of other things.
But I do get the feeling, though, and again, lightning would have to strike, and you have the House, the Senate, and the White House, as far as Republicans are concerned, to give a Trump White House the power in both the House and the Senate. And I think if that happened by even a slim margin, there would be a concerted effort to put something new to totally rework the health care plan. And he's mentioned that several times. And I think there would be a pretty good shot at that.
Yeah, I think, of course, it was tried back in, I guess, 2018 and was not successful in just repealing entirely the Affordable Care Act. And look, there's a lot of things that people can say about the Affordable Care Act, but, I would argue that most of it has been very good for consumers. A lot of opportunities to keep your kids on coverage till the age of 26. That certainly helps if you've got a kid that's in college or in graduate school that's trying to further themselves, further education. There's some opportunities there. There's some other good things about it.
Where did they come up with the number 26? I mean, come on.
I'm thinking maybe it's just because you can get those kids out of school.
Jeez. So, if they're in school still at 26 years old, you need to kick them out of the household. That's just that turns so many people off when you hear that, especially boomers. We're going to take care of you kids till you're 26 years old. Come on.
Well, those medical school students got 4 more years, so they may very well hit 26.
Let me say most of the households do not have medical students.
I totally agree with you. I hope mine is about 26.
Cons, C-O-N, and also illegals. Some of the other issues that are going to come up in the legislative session.
Yep.
Back with more next. I was, somebody asked me about a smash burger, and I said, I have no idea how a smash burger is better for you than the conversations we get on C Spire text line. A good smash burger, but we talked about hamburgers this morning. And here we are with a guy from the Hospital Association where they handle coronaries at a premium price. So there you go. All right, let me get back to this. Where are we as far as CONs are concerned, as far as the Hospital Association, yes or no, and because it's going to come up again, and I think being one of the top things to talk about as far as the 2025 session.
Yeah, so where the Hospital Association has been for, probably close to 10 years has been. It's just hard to have a really what I would just call a legitimate or an intelligent conversation about CON reform, certainly to the extent that it is just totally undone and its impact on hospitals until we address some of the uncompensated care costs, because there's federal laws out there that require hospitals to treat and service patients that come to them in the emergency department regardless of ability to pay. So you've got to have the ability to provide those emergency department services, and then depending on what the patient needs, you've got to have the ability to provide a higher level of care, and so regardless of the ability to pay at that point. So that makes it necessary that we continue to have a certain core of hospital services that our communities need. You don't know when you're going to need them, but you're going to need them at some point. A certain percentage of the population is likely to have to access those services. So what we've talked about for years are some things that we can do to help improve the Certificate of Need process. And in 2016, we led a lot of the revisions to the CON laws that increased the capital expenditures, kind of brought them more in line with where they needed to be, and then also increased the review process requirements and really kind of strengthened those laws and streamlined them so it would be more efficient and less costly for providers trying to access the system for CONs. So we have supported changes in CON laws. We've supported revisions to those laws all the way back to 2016, and just recently had some conversations about some things that the legislature, I think, is interested in taking a look at. That, again, wanting to improve access to care, but also realizing we've got to continue to be able to have a hospital. We can't get into a situation where more profitable service lines are just cherry picked off to stand up, a non-hospital venture that ultimately hurts all of us who at some point may need a hospital there.
There's so many different individual services, whether it's diagnostic or whatever it happens to be, that are not in these small communities. In most of these small communities where hospitals are, the hospital has, the town has underperformed the hospital size. In other words, you've got more room there than you need in a small town, because small towns are kind of dying away in a lot of cases, unless they're near a bedroom community of a vibrant community like Tupelo or a place like that. And that's just a reality across America. It's a changing landscape out there, socio-economically and healthcare. So my question is, and again, it's just from a layman who doesn't understand this business at all, but just one of those common sense things that a lot of people think. If you are in an underserved area, in a rural area where there is a hospital in the state of Mississippi, and there's no way a private or that hospital is going to offer that particular service, whatever it happens to be, and there's a multitude of those, then why wouldn't a hospital allow the con? They're not going to be competitive.
Well, I would say,
why wouldn't if it's not there, why wouldn't a con be approved?
Yeah, I don't know that that's actually happening. If the service is required by the community, if the service is supported by the community, the hospital or some other provider is going to be there to provide that service. So I really don't think that's the issue. And I'll say this too about our rural hospitals. Something else that MHA almost 100 years ago that was stated in one of the annual meetings is that, we need our rural hospitals. We need, and this was from someone associated with larger hospitals said this, but that we need our rural hospitals to be there. We need them to be successful, and we believe they can be as successful as our larger hospitals for their communities. And so, when you have a high school athlete get injured, you want somebody right there in those small towns that can be able to take care of them after 5 o'clock in the afternoon. And what I think we're seeing with our rural hospitals and with rural America in general, but I'll just speak to Mississippi. You may have a hospital that has a 25-bed facility. They're not staffing 25 beds. So really, the 25-bed is not a relevant issue. It's how many beds are going to be staffed. And but what we also see too is kind of a reverse impact of CON on a hospital, where you've got some of our rural hospitals that have told me that they might be able to keep a patient there in that rural hospital and not have to transfer them to Jackson or Memphis or somewhere else, if they had the ability to provide something like inpatient dialysis services. That they're blocked out from participating in a CON type of way too. That's been a hindrance for them. So they might have a patient that is in their small town that has pneumonia. That hospital is well prepared to take care of a patient like that and keep them in that hospital. But maybe that patient needs dialysis services. That hospital can't provide that there. So therefore, they get shipped out to a larger facility in a larger town. And so it kind of works both ways in some instances. Yeah. But the challenges in rural health care are really not just a CON type of issue. It's population size, it's revenue size, it's the payer mix.
Well, I understand that. Yeah. I understand that, but it's part of that. Part of the problems in a lot of these communities. Do we have all of our hospitals that deliver babies, or some of them don't?
Oh, many of them don't. Many of the rural hospitals do not, unless it's an emergency situation, but they're not having labor and delivery services.
I'm just looking at it as on a business standpoint. If you have, let's say, 30 rooms or 25 rooms, and just traditionally, annually, you probably have an average of only 5 or 10, then you've got, let's just say, 5 to 10 rooms that are not. Why wouldn't you con that out or bring that out to some other company that wants to come in, work within the hospital, and lease that part of it and deliver babies? It's on them. All you do is collect the money, the lease.
Well, unfortunately, it doesn't work that easily. You've got to have doctors that are wanting to come in and provide those services.
That's their problem, not your problem. All you're doing is taking the check and the profit on there. Well, you don't have to take anything else. You got the insurance; they're fully covered.
Well, if you had some physicians that wanted to come and do that in some of our rural parts of the state, yes. I think hospitals would absolutely have that conversation.
Could they do that without a con?
Yes. Oh yeah.
They could do that now without a con.
Yeah. Oh yeah. Yeah, okay. They come in and offer labor
is the reciprocal agreement we had that was passed a couple of legislative sessions before any help at all?
The reciprocal agreement on opening up the licensure.
We had hospitals that could work together, and they were in the past violating the law. Yeah.
Yeah, the community hospital statute that opened up some of the abilities of hospitals to collaborate. I think that has.
That made a difference.
I think that has helped. I think there's a lot more potential that we can tap into with that
Such
statute.
As?
Well, just like what we've talked about, if there's a rural hospital that may still be able to provide labor and delivery services.
But I thought you said they could do that now.
Yeah, they can do that now, and that collaboration agreement can help protect them and help get them some additional opportunities for things such as joint ventures, some different types of business arrangements that they want to set up and practice.
Can they do that as a leasee or just renting that and in the hospital itself and still be a private entity?
Yeah, I believe they can. You're talking about, like a community-owned hospital leasing something out to a privately owned facility? Yeah, I think they can do that. They can certainly do that under the collaboration law, the community hospital statute.
Before I run out of time here, in places like Springfield, Ohio, we're seeing, in a town of about 50,000 people, 20 to 25,000 immigrants coming in. They are, and this is one of the untold stories there, they're overwhelming the hospitals in that community. They have no idea what to do with these folks. It's costing the city. It's almost bankrupting the city. In the state of Mississippi, at any of our hospitals right now, if illegals show up at the hospital, they have to take them and see them?
If any patient shows up in the hospital emergency department, the hospitals are required to render care and services to them regardless of ability to pay. Yeah, it's just regardless of ability to pay.
Has nothing to do with whether they're a legal citizen or not?
That's my understanding. That's correct. That's EMTALA. So,
final segment coming up next. All right, final segment here with, Richard Robertson, President, CEO of Mississippi Hospital Association. Before you get to that one, Richard, I think you'll appreciate this one. One of the comments on C-SPAR text line. Paul, let me tell you how community hospital bill has helped us. This is the reciprocal. I'll let you respond to this. This is Mose. I go see our local doctor who's partnered with a larger hospital in another town. They file insurance. I pay my copay, and a month later I get an additional bill from the other hospital I never set foot in.
Yeah, so I think that was probably not the result of the community hospital bill. But, look, we're working with hospitals on price transparency and have done education on all that, and that bill is alive and well. So something to absolutely work on for patients.
What you would like to see in the 2025 legislative session that you think would help the rural hospitals or hospitals as a whole?
Yeah, so obviously the supplemental payment program has been a huge help that we talked about right off the bat. Our challenge in hospitals in Mississippi has just been the revenue issue. Most of our hospitals get their money from Medicare and Medicaid. It's about 65% of the payment source for Medicaid and Medicare. Payment source for hospitals is from Medicaid and Medicare. So, when you got about 65% of that coming from Medicaid, Medicare, another 3% from TRICARE, which is military insurance, and then a roughly 8 to 10% is uncompensated care, you're pushing about 80% of your patient payer mix is government funded or no payment at all. So it just leaves a little bit of a margin there, which is what makes it so challenging for those with commercial insurance. So that the revenue issue is still there. It is certainly improved with the supplemental payment. Anything we can do to increase that is helpful. And I say that not just because you're trying to soak up more revenue, but our Mississippi hospitals are the lowest cost in the country. Study after study, year after year, for 20 plus years, we have been the lowest cost hospitals in the whole country. And honestly, it's really not even close. And the gap has actually widened significantly. The rest of the country has far outpaced Mississippi in cost, which is a great thing. I say all the time, our hospitals do a lot more with a lot less than any other places. There's when you remove some of the higher cost services that are only being provided at a couple of hospitals, by and large, the rest of the hospitals are very, very low cost in what they do. You don't want to become just a low cost hospital in the sense of you suffer from quality, and we have not. We've consistently rated in the top half in some of the leapfrog scores. We've dropped just a little bit in the last year. I don't think that's a red flag or a trend. 1 year doesn't a trend make, or one actual half a year doesn't a trend make, But yeah, we provide very good quality services for a very low price compared to the rest of the country. So I want to commend our hospitals and all of our healthcare workers, our nurses, our physicians, our staff, folks who work in the cafeterias and clean the floors, clean the rooms, prep the surgery rooms and all that. They do a fantastic job for our state.
When you talk to your members across the state, we're deep into September now. Any changes for staffing needs from the first of the year? Is it getting better, worse, or about the same? Yeah. Nurses, doctors, et cetera.
Yeah, I think all the staffing issues have somewhat stabilized since COVID.
Good.
We still struggle to attract folks. Not just nurses and physicians, which are kind of the more well-known areas, but respiratory therapists, folks that work in labs. It's across the board. It's not just a hospital problem, but you talk to a lot of businesses and they're struggling to find folks that are able to fill their positions of need. The workforce challenges are real. Our workforce participation rate is very, very low. I don't know if we're the lowest in the country by percentage, but I know it's down there. So, it's not just hospitals and healthcare, it's across the board. You talk to business owners and they're struggling to find folks to work for them as well.
when you look at the ones, the hospitals, rural hospitals, or any hospitals that are on the IV or ICU, they may not be able to hold on much longer. Do we still have several like that in our state?
Again, it varies from from week to week, month to month. I think in some places, but yeah, I think some have some of those hospitals have given up inpatient beds to convert to rural emergency hospital status. That's a new program that the feds have just come out with that works for some communities. So I think communities just have to find what works best for them with their patient population and what the community will support.
Look, I appreciate you coming in and keep us certainly when the legislative session gets here. We'll call on you, and we need you to keep us informed.
I would love to come back, and good to see you again. Thank you,
Richard.
friend.
Good to see you, man. Richard Robertson, who's the new president and CEO of Mississippi Hospital Association. We got more on the assassination attempt and also on Springfield, Ohio, coming up.